Hey, we are back, as promised. We've got Dr. Whaley with us this morning. It's a beautiful day in the neighborhood. It's Friday. A little overcast here, a little chilly.
I got my jacket on.
Yeah. You going to take that off? Or
I got my pink tie.
Pink tie is nice.
I got my jacket.
Real men wear pink ties.
That's
exactly right. Anyway, we're live at Circle World this morning, as we always come to you on Fridays. We've got Ask the Doc with us today. Got Dr. William Whaley. BKP is with us, but he's not with us. So I know that's cryptic, but suffice to say, we've got the old gray experience at the helm today, and he's rolling his eyes at me right now. But anyway, we were scrambling here. You just can't believe
it. He moves a lot slower than Emily. Really.
I know. Emily's the best. I mean, let's call us beta shovel, right?
Like those kids doing the text message thing, right?
How are you?
Faster. I'm great. Yeah.
How was your week?
It was good. It's a little bit. It's emotionally exhausting to treat so many close friends and family members and treat them for cancer. It's nice to have a break. Come talk to you a little bit.
There you go. Well, we've got some great questions this morning. You want to start us off?
Well, yeah, I was going to say, my buddy Ray Tidman, who's a rocket scientist before he was a doctor.
That's amazing, isn't it?
I always like to say that. And
that's true. I mean, Ray went to Georgia Tech and he got a degree in aeronautical engineering.
And I think he messed around with designing airplanes or something a year or two before he decided to go to medical school. But anyway,
yeah.
So I always introduce him. When I refer
he's
patients to him,
resident rocket scientist.
I said he's a rocket scientist and he's a doctor. Anyway, Ray always has comments, about the primary care portions of the way these questions show, and so the guys at home with temporary malady, I think he has. Put it that way.
We'll just leave it at that.
Leave it at that. All right, let's go to work. This question for both of us, and I'm going to just go ahead and say that both of us are over 50. And
decades.
And between the two of us, at least as I think I've said many times before, I actually have prostate cancer, and I stay really up to date on this, and this is very, 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 very germane.
Yeah.
It's a very important question, and I want to give it a real good airing and answer this question, and then kind of come at it from other directions and answer some other questions. First, my husband is 70 years old and recently had a PSA elevation in his annual PCP exam, primary care physician exam. A couple weeks ago, we talked about the fact that there had been so little in the way of mammography, colonoscopy, and routine labs for a year during COVID that the incidence of cancer detection this last couple of months has gone up like a rocket, because people are getting mammography, having their colonoscopy, and going back to their PCP.
Now, for those that we're throwing a lot of acronyms at you. PSA, prostate-specific antigen.
Yeah, blood test for cancer detection.
That's correct.
It's the mammography for men over 50.
Right.
And it's generally done annually for men over 50. And she does say it was an annual exam, so we're going to make the assumption he has been doing it at least annually or every 18 months. So when you have an elevated PSA, a biopsy was done, and that's appropriate, and there is cancer number 6. Well, at least she got the number, not knowing exactly what that meant. We'll come back to that in a minute. He is in excellent health and only takes blood pressure medications. He plays golf 3 days a week, weather permitting. Up here, the weather permits a lot.
That's right.
Not so much in the winter. We have a good marriage and relationship. I think that's her saying that they still are intimate, is her way of putting it. Would you say that?
Yeah, exactly.
Yeah. He has been talking around to friends and wants to watch and wait. I am a breast cancer survivor, and I chose a mastectomy over a lumpectomy 12 years ago, and I wonder, would he be better with his prostate removed? So we'll stop right there for a minute. As you are aware, we have said that less than 3% to 5% of women choose mastectomy over lumpectomy when the two are equally presented as choices. And the reason is that they don't have to have reconstruction,
Right.
and they're left with two breasts. So this tells you a little bit about the wife's mindset. Her mindset sort of, if I offend thee, pluck it out. You got a cancer, take it off. I don't want to run the risk. So she's coming at it from that sort of perspective.
Right.
I know the urologist mentioned surgery and radiation, and he did not talk about watch and wait. And remember, I've always said to a hammer, everything's a nail, right?
Mm-hmm.
So that's treatment of the local prostate cancer in some fashion. I know you've talked about cases like this before. What is your advice? Well, my advice is to learn everything you can learn, and then let you and your husband, together with probably your PCP, think through the choices and then make the right choice for you as a couple.
So then the choices are two. You've got either active surveillance or you've got immediate treatment.
Of some sort.
Yeah.
Now, with immediate treatments, and that was a good way to introduce it. So let's put up the first one there, BKP. So I want to start right off, particularly with Gleason 6, which we'll talk about in a minute. And that first one says, what's that say?
Prostate cancer can be cured with appropriate treatment.
And with observation.
Yes.
And we can get that also can work. So let's put that boy aside. Now whip up the next one. Got that one up there about active surveillance? Okay, this is active surveillance is the term for, what'd she say, watch and wait.
Right.
I pull that down. You hear us talk about that every time we talk about chronic lymphocytic leukemia and well-differentiated lymphocytic lymphoma, right?
Mm-hmm.
Oh my God, she's got lymphoma, but the doctor says she's not sick and don't do anything. So that idea of active surveillance or watch and wait's not unique to the prostate. We see that frequently with chronic lymphocytic leukemia, and we talk about it all the time. Now put up every time, Emily over there, we always have to have a big old chart that nobody can read, and so we're gonna flash up this big old chart nobody can read, just so that everybody sees that this is a long, complicated thing that's not so complicated. So pull that down, and then we're going to go over.
Are you referring to the Gleason score now?
Well, no, yeah. Well, I'm for the total risk, okay?
Okay.
So here's what makes up risk. We'll just stick with this guy's got low risk, and so you just brought up Gleason's score. Gleason.
Dr. Gleason was around in the 60s, and he came up with what they call the Gleason
it's
score.
Looking under the microscope.
Yep.
How aggressive is this in two different ways? So there's two pieces of it.
Right.
And you add those two together. So Gleason 6 is 3 plus 3. Gleason 7 can be 4 plus 3 or 3 plus 4. That's a little too technical, but the first number is the worst. So if you got a 4 plus 3 is worse than a 3 plus 4.
Correct.
And they're both 7. Okay. So this guy would be, a very low risk. All right, because he's got, what we know here is he has no cancer that you can feel anywhere. It was all PSA. The risk groups, and there are 5 risk groups based on Gleason and based on how fast the PSA was changing and so forth. But the very low risk group is a tumor that only is found because there's a PSA and you have to find it by biopsy.
We know, excuse me for interrupting, we know that a PSA test gives you an indicator, but it also makes you move to the next level, which requires a biopsy.
Or an ultrasound or an MRI,
right.
Or some sort of investigation.
Right.
The highest PSA I've ever seen was in somebody who had nothing wrong with him. I think we talked about this about a year ago, and had ridden the bike from whatever that place is up there, Chickamauga to Sea Island at the brag race, bike ride across Georgia.
Right, just because your PSA is elevated doesn't necessarily mean that you've got prostate cancer.
He bruised his to death on a bicycle. See?
Yeah, exactly.
And it was normal in another 2 months.
Right.
It went from 10,000 back to 0.
Right.
Okay, so this man has a early tumor. It wasn't a cancer that was obstructing him. It was routine PSA. It's got a low degree of aggressiveness. That's the Gleason 6. And now, if you take somebody who, same story, PSA is elevated, not obstructed, gets biopsied, but his score is 4 plus 4, 8, or even 9, or even 10, even though there's no palpable disease, even though he's not obstructed, and even though it was the PSA that led him to the biopsy, he's in an entirely different and much higher risk group, okay? And so you have six different groups of risk between very low and very high, and each of these deserves a different amount of surveillance, a different approach to treatment. And remember that when you have breast cancer and you die from it, it's not the cancer on the breast that you die from. It's the spread of that cancer into your lung, your liver, your bone.
When it metastasizes.
Well, your prostate really doesn't make any difference how you treat the prostate gland itself for their local disease in terms of your long-term cure. It's that cell that got away before the prostate ever was diagnosed and then recurs somewhere else.
The key, the whole thing is when your urologist or when your oncologist tells you that your cancer has not gone outside the margin.
Of the, correct.
Correct?
Right. Now, there's two ways to get outside the margin. One is just to grow outside.
Right.
And the second one is to penetrate a blood vessel or a lymphatic channel in the gland, and then one little seed floats out there.
Yeah.
You can't see that. No
Right.
test will find that. All right. So now we're getting to where, okay, you wake up over there, Emily. We're getting ready to talk about the different ways of treating the prostate cancer. So pick up this next one here that says the advantages of. Okay, you got that one? Now, we put that up again because it's big old long thing. You're not supposed to read it up there. But if you take a quick look, at the top it talks about external beam radiation therapy, and then this would be seeds here, this would be radical prostatectomy, and down the bottom half is active surveillance. So you can pull that down there, BKP. So these are the advantages of different treatments. If you get to the radical prostatectomy, you got long-term cancer control, the thing's gone. If you had lymph nodes that were positive and you didn't know it on the scans, they're in there, they take them out. So you don't, but when you had that, you have got, you know what you had down there, all right? So if you externally beam radiated or put in seeds, then you're sort of missing the chance to take out lymph nodes, and you would be doing that probably with a different patient, maybe an older patient or one with less aggressive disease. And the advantages of those are that in the right patient, and we're not going to try and schedule that out for you, radical prostatectomy and seeds or external beam radiation therapy have the same survival at 15 years. So if you're 65 years old and they tell you, look, you can either have a radical surgical procedure or the radiation procedure, and your long-term survival is the same at 15 years, you stop thinking to yourself, well, look, I'll be 95 years old before this thing ever does me any trouble. You might accept, you're thinking then about how long am I going to live?
Right. So let's just say you're diagnosed. The doctor then has a responsibility to look at your age,
Right.
your comorbidity,
Correct.
and also probably your family history.
You're using a big word there. You mean your age and your general state of vigor and health.
There you go.
Okay.
Okay.
Comorbidity is the right word, but
Yeah.
we'll keep it down to country language. How strong?
Strong like bull.
Yeah, or do you have angina, or have you had 2 strokes? Or you got brittle diabetes, or are you? I guess 78-year-old guy came into my office yesterday, and he's been down here with what do you call it? Digging that thing, and he's a
Traco.
Yeah, a heavy equipment operator, for crying in the night. Like he's 50 years old, like that. So anyway, yes, all those things are
And the most susceptible age is probably 55 to 70.
Yeah.
Would you say that was?
To make the diagnosis, and there are a lot of 55-year-old people who biologically are 80, and nowadays with people so much on diet and exercise, there are a lot of 80-year-olds. I'm 81. still exercise all the time, that biologically are a lot younger. So that you treat the biological age. I'm not going to talk about George Burns again.
No, I understand. Yeah.
Okay. So anyway, let's
have a cigar.
Well, remember, he was still having sex with Las Vegas showgirls at 99, so you had to kind of treat him a little differently. So when you get to the active,
treat him like fine china, right?
What this lady's question is,
right?
When you get to active surveillance, what's the first advantage? Reduces over treatment, and we want to focus on that. You can't go too far, BKP, because you got to show another one here in a minute. But it reduces over treatment, and it avoids and prevents treatment-associated complications, and it has no effect on your ability to work, or you're not going to no leakage or any problems such as that. So we don't have that shown up. But now here's the story. BKP, show that last one. That's those vertical things here. This is kind of important. This is 100 patients on the left. That's all. That's 100 spots. And patients treated with active surveillance for Gleason 6 disease over a period of 5 years, only 3 are ever going to need to be treated. In other words, their disease is going to progress to the point where they have to go have radiation therapy or have a surgical procedure. So 97 of those would never have needed the operation or never have needed the radiation. You can pull that down, BKP. But that's a pretty impressive graphic, isn't it?
Yeah, it is.
It's a very, well, it's a look, and what does that remind you of? It reminds you of that graphic of the COVID, doesn't it? You got, except this number would be 10,000.
Yeah.
It'd be 10,000.
Right.
If you're talking about the fatality rate in children, it'd be 1 spot in 10,000. If you're talking about the fatality rate in 70-year-olds in a nursing home, it'd be 8 in 100 or something. So anyway, that we've used that kind of a graph many, many times. So at the end of the day, let's go back to the question. First, he has been talking around to friends and wants to watch and wait. So I'm going to say, I think that his golfing buddies have the right idea. The golfing buddies have the right idea. He at least should consider the wash and wait. And yes, you chose a mastectomy over a lumpectomy for your reasons. He may choose observation over surgery for his reasons. And you as a couple, with the help of your primary care doctor, who very assiduously made the diagnosis and got the blood test done, can talk it through. But I have the sense, listening to this, that the primary care doc and your husband and his golfing buddies will prevail. And with a Gleason 6 that was only found because of a PSA in a 70-year-old, I was 70 when mine was diagnosed, and I'm 81 now, and I haven't done a darn thing. I think maybe the golfing buddies will win.
There's been a lot of these procedures that have come along more recent than others, but radical prostatectomy has really come a long way.
Yeah, now I'm with that.
I mean, in years past, before robotic surgery was available, that was a tough surgery.
Well, let me tell you, when I was in training, and I remember I've been in practice almost 50 years.
Right.
Radical prostatectomy was 3 weeks in the hospital.
Exactly.
All right. And it was done in one of several ways. One, either you made a huge anterior incision and you had to go all the way down to the prostate and remove it, or they would go backwards through the back. But you're going deep in a great big old hole down there through a ton of meat.
Right.
In any direction, and it was a horrible operation. And then Dr. Catalona and his people invented the nerve-sparing procedure, which could be done much more gently and didn't give you so much in the way of
complications.
Yes, and Dr. Catalona invented that way before there were any robots. And I had patients that I sent to him, and he was in Kansas at that time, then went up to Chicago or Detroit or somewhere. But he invented the PSA. And then people from all over the world came to Dr. Catalona, and then the laparoscope was next, where you could do this through a scope and then puncture incisions.
Three
big old
3 holes.
Yeah,
Little bitty, about
Right.
3/4 of an
right.
inch.
But that was still before the robot.
Yeah.
It was like you do the gallbladder, through the telescope.
Right.
And then now they got the robot, and the robot really is a video game. You got a big old screen, and they're sitting there working these things like they're playing. It's amazing. But you always have to write the check to the doctor. You don't pay the robot. I was
Exactly.
laughing about that. But in truth, robotic surgery is sort of I don't know if they get any other thing, it's any less invasive than that. It's going to be where you go up and do like this, because this really is tiny incisions. You don't have much in the way of bleeding. People are out of the hospital 3, 4, 5 days, not 3, 4, 5 weeks, and the complication rates are extremely low. You still got surgical stuff. It's still
Yeah, I mean, you're still
an operation.
it's still the same. Yeah, it's operation, and the biggest thing is the healing procedure for not to get too deep in the weeds, but they literally excise your urethra away from the bladder to remove the prostate, and then you have to do an anastomosis back.
Well, what that means is that's the tube that you urinate through. So
That's right.
You're using the medical terms.
I'm sorry.
Here, I'm the guy giving you the okay.
Yeah, but
the tube you urinate through
Right.
is divided and then has to be sewed back together again.
Right.
Which is tiny little work.
Yeah, and then that literally,
It's like you're taking a very thin membrane that's no bigger than a small piece of what do you call that, angel hair pasta, and then sewing it up with a big old
with these arms.
Robot in a deep hole in the body. So don't ask me. It's magic.
Yeah.
I'm not a surgeon. It's magic.
So your PCP, your primary care physician, he or she diagnoses
That
you.
was sexist when you said he. Your primary care
I
physician.
said he or she.
You did, but
I
you
caught
started
myself.
You caught yourself. Yeah. Okay. Go ahead.
Anyway, they diagnose. They order. They tell
The
you.
right test.
They tell you need to go see a urologist.
Right, but let's stick with the PCP a minute. PCP also has checked your blood sugar or your cholesterol, or you're taking a history from the woman and said you need a mammogram,
Right.
or taking a history and said, oh, your uncle had polyps and colon cancer. I mean, you got to go see your primary care doctor often enough. I tell people all the time that are delayed cancer. I said, what kind of truck do you drive? And there's a 1996 Ford right there. It's, I got a F-150. How many miles you got on it? I got 350,000 miles on it, man. Never had a wrench on it. It's in great shape. How often you get the oil change? Every 5,000 miles. Religious. I said, now exactly when did you have your last physical and your last PSA? I haven't been sick. I didn't go see the doctor. That mindset that I take really good care of my car, but I'm not going to see my primary care doctor, we got to fix that. And there's a lot of that in these mountains.
Yeah.
All right. Anyway, so back to you. I'm just trying to say.
No. I understand. Now, so to wrap our arms around this whole thing is, go see your primary care physician if you're diagnosed. Go see the urologist. Do what the urologist says. He will give you treatment, whether they come and see an oncologist like yourself.
Sooner or later, they're going to have somebody talk to them about the non-surgical options.
Yeah, exactly.
But it'll happen.
Yeah.
All right.
All right. Let's.
Now this next question,
you want to get to the second question?
Yeah, I do. I think we have to. This is a good question, and this is what we call survivorship. How you manage people long term who this guy with active surveillance is going to be seeing it every year for
Right.
PCP for PSAs and MRIs and tests. Well, here this next patient has had continued cancer issues for years. I have a history of sarcoma in my ribs treated by big surgery and radiation 4 years ago at MD Anderson in Houston. Now I have locally advanced breast cancer in nodes, skin, and bones that scans say is responding to hormones and the TV drug Ibrance. TV drug means that's how that you see that advertised every day. And I don't know why they're advertising that drug, because you don't even know what it's about.
Exactly.
And they think you're going to go ask your doctor about
Right.
it. All right. So anyway, over the last 4 weeks, I have developed pain in my right side, and a scan shows 2 new spots on my liver. The oncologist has suggested biopsy of the liver. Why do I do that if I have breast cancer already being treated? Pretty good question, isn't it?
Yeah.
Okay, first thing that we learn is 4 years ago she got radiation to ribs. So that's, where are your ribs? Here in your chest.
Chest cavity.
Somewhere. And she was treated with radiation therapy. So the most common radiation-associated breast cancers generally were after lymphoma treatment. But sarcoma treatment, this woman had radiation that got on her breast. So her breast cancer might be secondary to the treatment she got that cured her of the sarcoma. That's the first thing. It may have nothing to do with it, but at least it markedly increases your risk. So,
Could have stirred something up, in other words.
well, it's just like sunshine causes these
Right.
things on your head, radiation can induce cancer.
Yeah.
And particularly breast is a sensitive organ to radiation given in that general region for some other purpose. That's the first thing. Now, her breast cancer that she's got is metastatic, and I don't know whether her breast cancer followed this or not. It doesn't say, but it is under control with hormones and Ibrance, and so it's a hormonally responsive treatment, and it is working. Now, all of a sudden, she's got a new symptom, and the new symptom is pain in the ribs, and a scan shows spots on the liver. Well, that explains the pain, So she probably has something in the liver. It can either be sarcoma that has come back in the liver. It could be breast cancer that comes back in the liver. Well, she's already had 2 cancers. Maybe she has another. Okay, put up that next one, BKP. It says secondary cancers. You got that? If you look at this thing, there's the liver.
Yep.
She's already told you she's got it in the bones from breast cancer. And there's the lung and the ribs. So it wouldn't be hard to imagine that either of those 2 tumors could have gone to the liver. But we're talking about secondary cancers. So this could be something else as well, couldn't it? So pull that one down, BKP. What's the next one here? Okay. This is in secondary cancers, the most common cancer that has a second malignancy associated with it is breast cancer. So patients who have breast cancer, and there's tons of them, are the highest group that can have another cancer, colorectal cancer, lung cancer, or something that is not spread of breast cancer, but a second primary. Pull that one down, BKP. And now, we've always got to have one of these, right? So, when you have a second cancer, way out here is the year that you had your first cancer, and then second cancer coming years after the original diagnosis. Basically, the longer you've lived, so this means people live a long time, then second malignancies can occur. This is the right-hand side of that's 30 years. You can pull that down, BKP. So basically what that says is you're never free of the surveillance of your first cancer, because you can have complications of its treatment or a new malignancy 30 years later. So once you're finished treatment and you've got 5 years or 10 years of survival, you still are going to have an annual exam with your primary care doc, or if you've had particularly aggressive treatments, radiation, some certain drugs, you'll probably stay with an annual exam with an oncologist. You got that?
Yep.
So what I want to tell you is you're going to have to let the doctor do what he says he wants to do, and that is biopsy the liver, because it could be sarcoma and you may need to change treatments. I would say it's unlikely to be breast cancer if all the breast cancer you can see in lymph nodes, skin, and bones is improved, and it could be a third malignancy. You've had 2,
right.
So you
You're
might
somewhat susceptible.
Yeah, you're somewhat susceptible.
Yeah, exactly.
Yeah, you're somewhat susceptible. It might be number 3.
Right. We
So
always
that's-
learn. We always learn a lot from these questions, and they're great. And
Well, I think people have gotten a lot better about asking them, don't you? Because, well, BKP will remember, how long have you been doing this? 4 years, 5 years?
I didn't have gray hair when we started.
All right. So, we've been doing this so long, I'm almost forgotten how long we've been doing it. But anyway, back to the story. Some of the early questions was, man, I don't know exactly what they're trying to ask me.
right.
So we've always asked to give us as much history, family history, and any catchphrases or words. Like that first question, she said, prostate number 6. Well, that's all you really needed to know. And you popped right up, that's a Gleason score,
Yeah.
So, and then sometimes they'll say they have cancer and it's number 4. Well, that means it's stage 4 and it's metastatic. So as much information as you can give us, give it to us.
Let me ask you, somewhat related. When you have a patient that's been diagnosed with cancer and they've been treated, do you ever recommend a genetic test?
Oh, well, frequently. I did that yesterday twice.
Okay, so tell us really. I think that's important. Now, a genetic
There's
test.
a lot of different genetic tests. First, if you have a newly diagnosed prostate cancer in a person that looks like it's going to be an issue, let's say it's a Gleason 7 or a Gleason 8, there's a specific panel of gene tests that are done on your prostate cancer to tell you if you're likely to have a worse outcome, and they're the similar to what you do in breast cancer. The Bracca genes, you've heard Bracca,
Right.
So yeah, so that's testing of a specific tumor. As we've said in lung cancer, they all get a panel of genetic tests because there are some treatments that are not chemotherapy that are easy to take that attack a certain gene that changed in that cancer. So that's a genetic test. Now, the other way is genetic counseling. Genetic counseling is when mother had breast cancer, her sister had breast cancer, my grandmother had breast cancer. We would genetically counsel this patient who does not have breast cancer at all.
However,
They would then construct a family tree, and then they start calling around, and call their grandparents or aunts and uncles, and discover 3 or 4 people on this side of the family, one generation back, had prostate cancer.
right.
And then when they put all that together, the genetic counselor, talking to this person who has had no malignancy themselves, will then tell them, I believe you should have a genetic panel done on yourself. And then they will test
Then
that patient.
they check the markers.
They check they check the genetics and say, okay, you do have Bracca. Now, who's the famous movie star that had Bracca, that had a mastectomy and a hysterectomy? Was she married to Brad Pitt or she married Billy Bob Thornton? Angelina Jolie. Angelina Jolie did more for breast cancer genetics than every doctor in the world, because she was so upfront about beautiful women having mastectomy and reconstruction, hysterectomy, because she was Bracca positive and she was going to have cancer. So she did more for, it's like when a famous person comes out with depression and admits it and takes medicine or goes into alcohol treatment. But Betty Ford did more for alcoholism and alcohol treatment than all the addictionists in the world, by admitting what she did, going in and getting treated, and then setting up a hospital.
I think Kayleigh McEnany as well, the press secretary for Trump. I think she went through the same thing, and she was very forthright with it, and
it's one of these liberal women, Katie Couric. She was, you don't want to hear about Katie Couric. I think she did the colon cancer.
She did.
So anyway.
Her husband died of it.
Yeah, so anyway, what I'm saying is that you're right. So the genetic testing is of several different types. One, the guy with a specific tumor, has nothing to do with your parents, your brothers, and your sisters, is your cancer driven by a specific genetic change that we can use in the treatment by choosing drugs that are genetic, attack a certain gene modification. And that's the one that is the Bracca and so forth. And the second is, what is my risk of cancer, or my children and siblings' risk of cancer, based on my family history and my genetic testing in broad terms. So both of those things, and I recommend those every day. And we have a huge genetic counseling program within the Northside Comprehensive Cancer Center of Georgia Cancer Specialists.
At Northside, affiliated with Northside Hospital. We got it, yeah.
We got it. All right. But we have a huge program. And actually, we're required by our electronic medical record with every newly diagnosed cancer to check the box that we have discussed and considered genetic testing for 100% of the patients. Now, we don't recommend it and all, but we have at least discussed it and decided, yes, we will, or no, we won't.
Yeah, someone talked to me about that, and, that's why I wanted to bring it up, because I think that's really important.
Yeah,
important in the testing. Let me give a shout out to Northside Hospital. My wife was in one of the campuses. I was in another campus. I've been in Atlanta for a number of years, and
don't tell them how long.
Yeah, exactly. Northside Hospital really, in my mind, has come a long way.
Oh yeah.
And I can't say enough about, the quality of the staff, from top to bottom. And it's just, when I say, when you say I'm affiliated with Northside Hospital, to me that means something.
Yeah.
Whether it be the Cumming campus or the mothership in Sandy Springs.
Yeah, I practiced there one day.
Yeah, that's right. It's
I was on the staff of that hospital when it was built, and that's a long time ago.
When it was built, it was kind of known as a that's where you go to have your baby.
Yeah, and also it's funny when they first built it, there was a tremendous, and it had only been open a few months. There was a
What are you doing, 2 hours?
terrible ice storm.
Huh?
What
Yeah.
are you doing, 2 hours?
Yeah, we're doing 2 hours. There was a terrible ice storm, and people were falling and breaking their hips. And going to Northside Hospital, there was one orthopedist out there, yeah. And I'm not going to tell you his name, but he had a Volkswagen, and he could go on ice. And it established him as the go-to orthopedist outside the perimeter for 3 decades.
Wow.
And he started a huge group. That'll be enough said. But Northside Hospital and the ice storm came together at the right time to make him a famous man and make him very successful.
Awesome.
BKP wants us to wrap it up, and I don't see anybody back in the green room. Anybody in the green room?
I think part of the All-Star panel is here. Yeah, Bruce is here.
All right.
Anyway, we always learn a lot. We truly do. And I can't recall. Brian, help me out. If someone wants to ask a question, they send it to
info@FetchYourNews.com. It is on the screen. You can see it now.
Great.
Right there. info@FetchYourNews.com. And then also follow us on the social media and send Ask the Doc questions.
Excellent. Thank you.
Half of these questions come to me in the office, by the way.
Well, that's good.
They know how to find me.
Yeah, that's good. Anyway, once again, this segment has been brought to you by Georgia Cancer Specialists, affiliated with my favorite hospital, Northside.
Right.
And we appreciate every week you coming in and sharing your expertise with us.
Yeah, let's send some fluids to Ray.
Maybe some Pedialyte, huh?
All right, get some Pedialyte, Ray, or some real Coke.
Yeah.
No, not Coke. We're not buying Coke.
No.
Pepsi.
Yeah. See, this is off the market. You can't even buy this anymore. We've got our own little private stash here, so we're doing our own thing.
We're not buying any more Coke products after the restricted.
There you go. There you go. So anyway, okay, we're going to take a quick break. When we come back, we'll see if Joeen's here with us. Bruce is here with us. And, maybe we need to get BKP to shout in every once in a while. I'm sure he will. He just can't help himself. But I'm glad to be in for BKP this morning. And we'll take this time to take care of the people that make this show possible. Take us to break, BKP.